Live from Philadelphia, my name is Rifat Manan, and welcome to this edition of Pathcast. Today I am joined by my friend Emilio Madrigal. He is in Boston right now. Today is Wednesday, March 25, 2020. As pathologists, whether we are in training or as an attending, colorectal cancer is one of the more common problems that we encounter in our daily practice. And often we are used to listening to a pathologist version, whether in our program from our attendings or in the national meetings, of how to deal with colorectal surgery or colorectal cancers, starting from gross examination, taking sections from the specimen, how many lymph nodes we need to dissect, different aspects of histologic evaluation, prognostic factors, and of course, cancer biomarker tests, to name a few. At the same time, we should not forget that there is a surgeon at the other side who has sent the specimen to us, who is taking care of the patient, and the report is gonna go back to the surgeon. So based on this report, she or he will decide future treatment strategy for the patient. At the center of both the pathologist and the surgeon or the oncologist, we have the patient, and as we all know, patient care is the final goal for all of us. Let's hear from a surgeon what the pathology report means to her, or what aspects of the report are more important as she decides future treatment options. Today, we are happy to welcome Dr. Nicole Saur, who is an assistant professor of surgery at the University of Pennsylvania. Over the next 1 hour, she will discuss a surgeon's perspective about how she reads the pathology report on colorectal cancer patients and how the report affects her treatment options. Thank you, Dr. Saur, for joining us. Over to you, please.
Yeah, thank you so much, Dr. Manan and Dr. Madrigal, for having me. I'm truly honored to be part of such an innovative podcast. As you said, I'm going to be speaking about how surgeons interpret the pathology report. I have no disclosures. So what is the importance to us and to our patients of the pathology report? So I think a picture is worth 1,000 words. And so we know that as people go through the process of being diagnosed with cancer and ultimately having surgery, one of the first things that they ask us is, what is my prognosis? What will my quality of life be? Some patients are worried about how the prognosis and the diagnosis will affect their quality of life. Others are worried about what the pathology report is going to say and what that means for their upcoming treatment and again for their longevity. And others are kind of waiting for that, what we presume to be good news from an early stage cancer. So often when we finish surgery, the patients say thank you, but generally the next thing that they say is, when is a pathology report going to be back? So I wanted to speak today about how we interpret that and then how that translates to our patients and ultimately to their outcomes. So this is the synoptic report, of course, that you are all very familiar with. And so I thought that the best way to go forward would be to pick out specific things from your report that are most important to us, so that if there are little things that might take time for you to differentiate that are more important versus less important, you can have the surgeon's mindset in your mind. So we'll go through the specific pieces, and there are some pieces that I'll skip over because they're not as important to us. But also, when I'm speaking about this, I'm speaking generally about colon cancer and rectal cancer, but when there's a distinction, I will make that clear. So just a couple of words about procedure, because sometimes we say a procedure and different people mean different things. And so basically we break it up into right colectomy and left colectomy for colon cancer. Sometimes we say sigmoid colectomy if we just take the sigmoid, but it's all based on the blood supply and the lymphatic supply. So for the right colectomy, we're going to be taking the blood supply and the lymphatics based on the ileocolic artery. For a left or a sigmoid colectomy, we're going to be taking that based on the inferior mesenteric artery. Then we have the distinction between low anterior resection and abdominal perineal resection, which generally take the same blood supply from either the IMA, or sometimes for the abdominal perineal resection, people go a little bit lower onto the superior hemorrhoidal artery. But the distinction here, of course, is whether or not we're able to preserve the anal canal and proceed with a coloanal anastomosis, or whether we take out the entire anal canal as an abdominal perineal resection. So from the pathology report, the first thing that came to note from this order was tumor perforation, because obviously we know that if the patient has a gross perforation, they present with peritonitis and they have to go to the operating room. That's obviously clear to us at the time of surgery, but sometimes there's a microscopic perforation, and that can also have implications on the patient's prognosis. So if that is noted, that's something that is very important and often will change the treatment strategy. So even if there's a small perforation and the patient has, for example, no lymph nodes and would otherwise not get chemotherapy, that's often a patient that will get chemotherapy. And we just know that the higher mortality is associated with perforated cancers, a higher 5-year local recurrence, and a higher rate of peritoneal carcinomatosis, which again affects the surveillance and also the treatment going forward for the patient. The next thing, of course, is the type. And generally, when we're doing a resection, we already have a biopsy from a colonoscopy. So there's usually not a lot of surprises in terms of the diagnosis at the time of resection. But the time when we do get some surprises is at the time of biopsy. So for example, if somebody has a large, nearly obstructing colon mass, and it's biopsied on colonoscopy, sometimes the pathology report will come back and say at least high-grade dysplasia, as opposed to invasive carcinoma, because on the slides, there's no evidence of invasion. And this is something that we talk about a lot at tumor board, because of course the surgeons and the oncologists will say, well, it's clearly invasive. It's this large, bulky mass. It's very clearly not a dysplasia. And then rightfully so, the pathologist will say, right, but what I can see on my slide doesn't show invasion. And so the way that we deal with that is typically if the disease is local, so if they have a large mass but it's not metastatic, we will typically resect without an invasive diagnosis, because we know that we'll get the final diagnosis from the final pathology. The time when it becomes a little bit more tricky is when somebody has metastatic disease and they would otherwise get chemotherapy. In that case, oncologists are usually hesitant to give chemotherapy without an invasive cancer diagnosis. And in that case, we will often either biopsy the primary again, or sometimes we'll biopsy the metastatic disease to try to get the invasive diagnosis and clarify that the metastasis is real. So then for the extent of invasion, this is the colon and rectal cancer staging. And I put the entire AJCC 8th edition staging on here just to show how complex it is. But then I broke it down for the way that surgeons mostly think about it. So when we talk about stage 1, it's T1 versus T2. Stage 2, it's T3 and T4, but both of these with no nodal disease. Stage 3 is any patient with nodal disease. And then stage 4 is patients with metastatic disease. So for focusing on where splitting hairs makes more sense to us, so for example, if the specimen is fully resected, so if we have a right colectomy specimen, it's not as important to us if it's T1 versus T2, but it is important if it's T3 versus T4, because generally speaking, patients with stage 1 and stage 2 disease don't get chemotherapy, but T4 disease is something that generally makes the patient eligible for chemotherapy. So T3 versus T4 is an important distinction. And then of course, whether the patient has nodal disease, because any nodal disease generally indicates that the patient should have chemotherapy. And of course, if it's node positive, that would indicate that. So that's the other important thing. And we'll talk more about nodal disease as we go forward. The other important distinction, which I really think could be an entire talk, and I've talked about that with Dr. Manan for the future, is the resected polyp. So there's two important distinctions for us. First of all, whether it's the carcinoma in situ or intramucosal carcinoma versus T1, because of course we're not going to do any further surgery for the carcinoma in situ, but T1 sometimes requires a definitive cancer operation. So the high-risk features that are really important to us, and we'll talk about this a little bit more going forward as well, is lymphovascular invasion, tumor budding less so, whether it's poorly differentiated, what the SM level is, and of course a close margin. So sometimes if the patient only has a close margin, they'll be able to go back for re-excision. But if they have others of the high-risk features, especially if they have multiple, then we generally recommend a resection because they could have up to 25% chance of having lymph node metastasis. And there's not a good way as of yet to detect occult lymph node metastasis without doing surgery. Otherwise, we would just be waiting essentially for metastatic disease to develop. This is a cohort study out of Denmark and Sweden where they looked at over 1,400 patients. And they were looking at risk factors for lymph node metastasis, which is a really hot topic again in colorectal surgery, because we want to be able to give our patients some degree of certainty about what the likelihood is that we're going to take out the colon and the lymph nodes and potentially change their bowel habits to give them a negative specimen versus leaving tumor in place that's then going to spread and alter their longevity. So being able to counsel patients is one of the most difficult things that we do on these malignant polyps. And this is why I think that this really could be an entire hour lecture on its own. But just in brief, they found that the kind of typical risk factors were present: lymphovascular invasion, perineural invasion, mucinous subtype, and also younger patients had a higher chance of lymph node metastases. And these were all independent risk factors. And then the kind of classic SM level, so SM3 or deep submucosal invasion, was actually only a dependent risk factor, and it was not significant on multivariate analysis. So again, I think a lot of these things are cumulative, but the more things that you give us in the pathology report, the more factors that we can use to help educate the patients, the more informed decision that they can make with our help. So this is a really large part of the talk, is about margins, because this is something, of course, that's really important to us as surgeons. And it's also a really good way for surgeons to collaborate with pathologists and for surgeons to kind of learn about what their quality is. So this is a point where colon and rectal cancer become a bit divergent. So we'll talk about colon cancer first. So in colon cancer, when we're doing our surgery, of course, we're basing our lymphatic drainage off of the blood supply, and we're also making sure that we take a gross 5 centimeter proximal and distal margin from the tumor. So this becomes important, I think, sometimes because, for example, if I operate on a Friday and the specimen goes to pathology, by the time that it's grossed on Monday, a lot of times that 5 centimeter margin has shrunken down considerably. And so this is an opportunity, I think, especially if there's any question about the margin, to have the surgeon and the pathologist collaborate at the time when the specimen is fresh to ensure that we truly have a 5 centimeter margin before processing. And then, of course, we always want to have a negative radial margin, but unlike rectal cancer, which we'll talk about shortly, this is not typically determined by the quality of the surgery. It's more based on the tumor characteristics, because there's not typically any part of the margin that would be left behind based on the way that the surgery is performed. So with that being said, I thought it would be useful to show some videos of how we actually do the surgery, and quite frankly, why we're so neurotic about the way that the specimens are processed and the lymph nodes are tallied, because we put a lot of energy surgically to get that specimen, but also at certain times some risk to the patient with being sure that we're getting this high ligation and removing all of the tissue. So this is a laparoscopic right hemicolectomy. You can see the cecum and the appendix there, and we're tenting up the ileocolic pedicle. And this is what they call a medial to lateral dissection. So very shortly after we get under the pedicle, we're going to see the duodenum. So now we're dissecting between the retroperitoneum and the mesocolon so that we can get that entire mesorectum to be evaluated as a specimen. And again, in the foreground, you can see the ileocolic artery tenting up. So we would continue this dissection all the way up to the transverse colon underneath the mesocolon, and all the way laterally, you can see the kidney up in the left side, and you can see that the kind of lateral colon is over to the left as well. So now we're going to skeletonize the ileocolic artery, and then we're going to perform a high ligation. And I left this part of the dissection in. It's a little bit tedious, but just to show that this is something that we spend a lot of time doing because we want to be incredibly meticulous about making sure that we have a high ligation, that we're getting the entire lymph node pedicle. And again, you can see the duodenum is right below us. So there is some risk of injury to surrounding structures like the duodenum, and on the lateral side, the ureter. So we're going to clean the rest of the pedicle. And then, like I said, we'll perform our high ligation. So then we'll have our lymph nodes coming down along the artery, and then all along that we've taken basically up to the transverse colon as well. And again, because this is a high ligation, there's a pedicle there that can sometimes be difficult to control. So there is some risk to the patient, which is why we're coagulating the vessel several times just to ensure that we have hemostasis while getting all of the lymph nodes that we need. Then we would continue this dissection up toward the transverse colon so that we get all of the included lymph nodes. So now you can see that we've chosen our transection point on the transverse colon based on the blood supply and also based on the tumor location. We're just finishing up some of that mesocolic dissection. So now we're coming around laterally to take the attachments, and you'll see very shortly that we're going to meet up with the dissection that we did from underneath. So that's what that little defect there is. So now we'll be able to come all the way around the hepatic flexure and free up the colon. So now we've freed up the lateral attachments, and we've also freed up the mesocolon. Keeping in mind that up to the left is the spleen. Of course, we've got the gallbladder and the liver in view, and then down posteriorly, you can again see the duodenum. So we're keeping all of these structures in mind as we're dissecting the colon free. So now you can see that this specimen is freed up, and there's just a little bit of mesentery at the ileum that needs to be freed up so that we can perform our resection and then ultimately our anastomosis. So this is the reason that surgeons are often really particular about having 12 lymph nodes in a colon specimen at least, because there's been a lot of effort in being really diligent to get all of the lymphatic tissue removed. So the next step is going to be to divide both the small intestine and the colon. And again, you can see the duodenum here immediately. So we expose the duodenum all along its entire length. That's showing the more cephalad portion. So now we're taking the mesenteric dissection up all the way to the small intestine here. And then we're going to divide the small intestine and ultimately the colon, making sure that the bowel that we have left has an adequate blood supply for healing. So now we're stapling off the small intestine. And then again, we'll do the same with the colon, noting the pink and the purple bowel that we have our distinction based on where we took the mesocolon, which is based on where we're going to take the bowel. So we make sure we have nice perfused bowel that's left behind for the connection. We're just going to divide this last little bit of fat here, and then we'll have our specimen completely removed. Based on all of the work that we did freeing everything up, then we'll be able to bring the small intestine and the colon together. This is the creation of the anastomosis. Basically stapling the two lumens together. And then we're going to be left with what we call a common channel. So this defect here, and then we're going to close that with some sutures. So this is just showing the end of the suturing where we're just basically putting the last stitch in. This is a 2-layer closure where we ran the stitch down and now we're running it back up again. And you can see that the connection is large and it's also nice and pink, and that everything is closed up. So this is the the short part of the laparoscopic right colectomy. And again, the really important part that we're focusing on is making sure that we're getting adequate margins on the mesocolon and also proximally and distally. So when we compare that to rectal cancer, this is a walk in the park. Rectal cancer is a lot more complex because of the need for a total mesorectal excision. It's for middle and low rectal cancer. So that's what we'll focus on when we talk about a lot of these margins. Again, we need to remove the entire mesorectal envelope and all of the appropriate lymph nodes and the tumor itself. So this is another video showing the complexity of doing the TME, the total mesorectal excision. This is just looking for metastatic disease, which we do at the beginning of any cancer case. We look at the peritoneum and the liver to ensure that there's no metastatic spread before we subject the patient to the resection. This is starting the pelvic portion of the procedure where we dissect into the presacral plane to get the total mesorectal excision. And I just show some highlights to show that there's this areolar plane, but it can be a little bit difficult to decipher, especially in patients with more edema from radiation or from a really bulky tumor or narrow pelvis. So technically speaking, rectal cancer surgery is a lot more difficult than colon cancer surgery. And the stakes are very high because we know that if we don't get a complete mesorectal excision, then unfortunately we have a higher chance of recurrence, which we'll go through a lot. So this is why the margins are very important to us in rectal cancer surgery, because of course your feedback can give us an opportunity to improve, but also because it really is high stakes for the patient. So we're continuing this dissection really meticulously, and this is just a very edited version, but basically the point is that the dissection is very meticulous so that we can get that really nice mesorectal excision that we hopefully bring down and discuss with you in pathology. So now we're about to skeletonize the inferior mesenteric artery. In an earlier part of the case, we have already taken the inferior mesenteric vein and mobilized the colon at the splenic flexure to be able to create a connection. So now we're just finishing that up, and this is going to show you again the IMA, and we're going to take all of those lymph nodes, keeping in mind that right at the same level, you can see a lot of sympathetic nerves for sexual and bladder function. And of course, we're right on the aorta. You can see the iliac artery pulsating there. We have to worry about the ureter. So again, this is not for nothing. Sometimes we are a little bit more aggressive in terms of the mesocolic resection. And then, of course, we put the patient at risk for other complications like nerve injury. And that's the reason that we're really particular about the way that the specimens are analyzed for these patients. So now we're just continuing into the presacral plane, and we're taking the specimen posteriorly. You can see we're getting really low into the pelvis. And if you look posteriorly, you can see the sacrum and that kind of glistening capsule. There's some more areolar tissue that we're going to take here, and we're going all the way down to the levators, and then we're going to divide the rectum. So just a very painstaking, meticulous dissection as we get this complete mesorectal excision here. The last step is that we're going to finish the anterior dissection between, in this patient, the vagina and the rectum. And you can again see that the pelvis is empty. We have this really nice mesorectal envelope, which is intact. And we're just trying to narrow down the specimen so that we can staple and ultimately remove the rectum. Again, a nice view of the pelvic floor, and just one more little bite here, and then we're going to go to the front to finish the very last bit of dissection. So then this is the anterior portion where we're dividing the plane between the rectum and the vagina. Of course, we want to make sure that we are not injuring the vagina or including in our anastomosis. So we'll show that as we go along as well. You can see the peritoneal reflection, which is an important landmark for us. And I know that that's part of the synoptic report as well, where the tumor is in relation to the peritoneal reflection. Just some more of this areolar plane anteriorly. And then this is just showing that the stapler is on the distal rectum, the vagina is free from the stapler, and the rectum is being divided. And again, the rectum is being pulled up, so it doesn't look like it's quite as low as it is, but I'll show a view in a second where you can see that the staple line is really just flush with the levators. So we're really down very low at the pelvic floor, adding to the technical complexity. This is the empty pelvis. You can see that all of the mesorectal tissue has been removed. And then again, that the staple line is very low in the deep pelvis at the pelvic floor. It's just one more view of the same. So now the important part for the pathologist is over, the specimen is out, but now we're going to perform the anastomosis where we hook up the anus to the colon and then staple the two together. So that's just what this is showing. We'll close this stapler and then it fires 2 rings of staples. So this is the specimen for that particular patient. So in the upper left, you can see that the IMA, where the clip is, has a high ligation. We also take the IMV, not necessarily for oncologic purposes, but just for reach for the colon to reach down to the pelvic floor. You can see that the mesorectum is intact. On the bottom images, you can see the staple line of the distal margin and the nice bulky mesorectum all the way around. So again, in rectal cancer, this is an opportunity for the surgeon and the pathologist to really collaborate. So the surgeon and the pathologist should review the TME specimen together post-op versus intra-op, especially for low rectal cancers. So they did a study where they did 8 intra-op consults for low rectal cancers, and the median distance of the distal margin was 10 millimeters, but the shortest margin was 2. So in 6 patients, they had sufficient margins for reconstruction. In 2 patients, they needed an APR. And in 3 patients, the pathological assessment actually affected the operative strategy, which was about a third of the patients. So 1 patient was able to avoid an abdominal perineal resection, and then 2 patients actually required it. So this is an opportunity, I think, for collaboration to determine that the distal margin really is grossly negative so that it's safe to do a reconstruction, or that it's actually not going to be possible to have a negative margin, and therefore the patient really does require an abdominal perineal resection. The other area for collaboration, of course, is the completeness of the TME. So when we talk about the completeness of the TME, sometimes the surgeon and the pathologist have a little bit of a different opinion about it. But we know that it's really important to get an accurate grade, because we can also get some feedback and maybe improve our technique based on the grade of the specimen. So of course, a complete is an intact, bulky mesorectum, no defect greater than 5 millimeters, and for an APR, no coning of the specimen. Near complete might have some very superficial defects, and then of course, incomplete has a visible defect, as you can see here in figure C. One of the seminal studies showed that it doesn't have a significant prognostic difference between complete and nearly complete, but complete and incomplete have a vastly different chance of local recurrence. And so that's the reason that the grade and the completeness is very important to us and to our patients. On the same line, the circumferential resection margin is incredibly important. So 586 patients underwent a TME for rectal cancer with 5 years of follow-up. Out of that, 28.2% had a positive circumferential resection margin, and out of the whole cohort, about 18% of patients developed a local recurrence. But out of that group, the recurrence rate was almost 40% if the circumferential resection margin was positive, and only 10% if it was negative. So again, it's very important to us as surgeons to know what the circumferential resection margin is. And sometimes this can be correlated on a pre-op MRI, because sometimes the positive margin is related to the surgical technique, and sometimes it's just related to the fact that the tumor is extending all the way to the margin. Equally important is the distal margin. There was a very large cohort of over 6,000 patients where they looked at greater than 1 millimeter versus less than 1 millimeter distal margin, and greater than 1 millimeter has a better local recurrence rate, disease-free survival, overall survival, and distant recurrence rate as well. And the reason why this is important is because, of course, we want to shoot to have at least a millimeter margin if possible. But also, if patients had a microscopically positive distal margin, then they had a better disease-free survival if they had adjuvant chemotherapy. So again, that can change the treatment plan. I put the proximal margin just for completeness, but that's generally not important in rectal cancer surgery. The last thing is bread loafing of specimens. So this is really important in rectal cancer because it allows for comparison to the MRI. So you can see based on the preoperative MRI and the specimen where maybe there was something that we called as possible invasion, but then when we looked at the pathology, it wasn't. So we can give that feedback to the radiologist and we can all improve together. So it not only is easier for us to see the pathology, but it also helps us to kind of correlate to what we're seeing preoperatively. And again, this is just stressing the importance of doing the bread loafing for these rectal cancer specimens. So then we have other high risk features like lymphovascular invasion, perineural invasion. This comes into play more in patients who otherwise wouldn't be getting chemotherapy. So that's when we think about stage 2 patients. Because generally speaking, if you were to answer on a test, you would say stage 2 patients don't get chemotherapy, but these are the exceptions. So if they have a T4 tumor, as we discussed earlier, poorly differentiated histology, unless they're MSI high, which we'll talk about shortly. Of course, lymphovascular and perineural invasion. And then for us, bowel obstruction, perforation, close margins, and then inadequately sampled lymph nodes. Another reason that we really want to make sure we're getting at least 12 nodes. And so on that note, we'll talk a little bit about lymph nodes and also tumor deposits. So we always hear, we want 12 lymph nodes. We want 12 lymph nodes. I'm sure the surgeons are bothering you if you're not able to find 12 lymph nodes and you're scouring through the fat trying to find some more. But we know that we can expect less than 12 lymph nodes in rectal cancer after chemoradiation. So they did one study looking at 176 patients, and 28% had the standard greater than 12 nodes, but 32% had less than 6 nodes. So we know that this is not correlated between the number of lymph nodes harvested in this case and the number of positive nodes because of the effect of chemoradiation. So if you have a right colectomy specimen, then we're definitely going to want 12 lymph nodes. Whereas if we have a rectal cancer specimen and you've looked at an infinite number of slides, it's generally safe to stop because you're not likely to find more lymph nodes. Just a note on tumor deposits. So we treat tumor deposits in a broad sense like positive lymph nodes. And that's because when they looked at N0 tumors without tumor deposits, the 5-year survival rate was 91.5%. But when the tumor deposits were present, it was 37%. So generally speaking, when we're talking with oncologists, we treat the tumor deposits as if they're a lymph node. Just another word on stage, just to say that all of the work that you're doing, we're able to put together and then ultimately give the patient their stage. And a bit on immunohistochemistry. So at Penn, we have reflexive immunohistochemistry on biopsies or resection specimens. And there's 2 points when this becomes really important to us as colorectal surgeons. So first and foremost, the thing we always think about is differentiating sporadic mutations from Lynch syndrome. It's not that common. It's only 2 to 4% of colorectal cancers. But when people have Lynch syndrome, it can really affect their treatment planning. Maybe they'll have a total colectomy instead of a segmental colectomy. Maybe we'll be talking about adding on TAH BSO to a patient who's finished their childbearing. So that can be very important in the treatment algorithm. And so that's why we really like to have that information up front before the resection. And then the second reason is, like we talked about for stage 2 patients who are MSI high have a better prognosis, and they often don't respond well to chemotherapy based on 5-FU, which is our mainstay of chemotherapy. So they already have a better prognosis and their tumor is not chemosensitive. So typically those patients do not get chemotherapy in stage 2. And so that's why it's very important to have that information really early on. So in conclusion, the surgeons are incredibly reliant on our pathology colleagues. And I think that there's a couple of areas that are really of utmost importance to us. Like I spoke about in a lot of detail, the margins in colon cancer, but really particularly in rectal cancer, and having the opportunity to get some feedback about what could be done better potentially from a resection standpoint. And then, of course, all of these high-risk features are incredibly important to us because it could affect the need for additional surgery versus ongoing chemotherapy in the future. So thank you very much for your time and your attention, and I hope everybody is staying safe with the COVID pandemic going on.
Thank you, Nicole. Thanks for the excellent presentation. We have a couple of questions online. Let me read them to you. There is one question about tumor budding. So how tumor budding affects treatment for the surgeon.
Yeah, so like I said, I think that malignant polyp could be an entire talk on its own, and I think we should have that at some other point. In short, I would say that tumor budding is not, at least in my experience, always reported on, and it's not always reported on with a large degree of certainty. And so I would say if the patient only had tumor budding, that would probably be a discussion, but that's generally not the case. It's usually that they already have lymphovascular invasion or pleural differentiation or a close margin, and they have tumor budding. So it's usually, I would say, in our discussions, used as an additive point as opposed to something as a standalone.
So just to add from my understanding, so what you mean to say is that tumor budding alone in the report of a malignant polyp so is not that important for you in deciding future treatment. Is that right?
So I wouldn't say that it's not that important. I would just say that it's not variably reported, and it's something that there are some studies saying that it's very useful, but because of the fact that we don't always get it, and there's generally more than one thing positive at a given time, I would say that it's the gestalt of the entire piece. We present all of these cases at Tumor Board, and I think having the pathology representative there to discuss is also very important. But I haven't ever seen in my practice where the only high risk feature is tumor budding. It's generally that there's others, and that becomes more cumulative.
So for you in that report, lymphovascular invasion, poor degree of differentiation, so all these things go together. Is that right?
Correct. Yep, exactly. That's why we really would like it all. I mean, if we could get all of those things that I mentioned, that would be the ideal, and then we can put them all together.
Right. So thank you so much. There is another question that I can see online. The question is, can you please highlight the difference between colon perforation and tumor extending through bowel wall into pericolonic fat?
Yes. So I think that the tumor extending through the bowel wall into the pericolonic fat, I wouldn't necessarily call that a perforation. I think that from my perspective, it seems like a perforation would be more of a local inflammatory response that you can see that there's some kind of maybe microperforation at the site of the tumor. Otherwise, you'd probably just be calling that a T4 tumor. And from a practical standpoint, it probably doesn't change management because either of those things are high risk and they would therefore get chemotherapy.
Right. So there is another question on the same line is, how do you stage a tumor that was perforated by a surgeon during operation? Will it be PT4?
Yeah, that's a very good question. And that's why I really think that the pathologist and the surgeon need to have a really collaborative environment, because we actually just had this about a week ago. I was doing a really difficult abdominal perineal resection, and when we continue the dissection anteriorly, which is the last part that we do, we actually evert the specimen. So now we have the rectum attached to, in this case, the prostate, with the rectum kind of looking like a knuckle, so to speak. And so what happened is that we had already done our really beautiful circumferential dissection, but we got a little bit too close to the top of the knuckle, and we actually made a very small hole in the rectum itself. proximal to the tumor. And so then I came and I discussed with my colleagues because I wanted them to know that that was a, Saur perforation and not a perforation of the tumor itself, and also that the circumferential dissection is complete. So to say that there's no tumor left behind in the pelvis, because that's always what we're worried about. If we see an incomplete TME where on that picture where the divot is present, then you worry that where that divot is, that fat is left behind. So to be able to say, no, there's no fat left behind, it was just that I made a hole in the rectum inadvertently, and this is something to keep in mind. So I think you really have to communicate with the surgeon, and hopefully the surgeon would communicate to you that, the colon was really stuck on the kidney and it was really difficult, and therefore this was a traction injury and not an actual perforation. And that's why I wanted to show the videos today, because I think that sometimes, we just dump the specimen off and we're maybe not as clear about the potential difficulties in doing the surgery. So I just think, communication. And I think sometimes, surgeons get a bad rap for not necessarily wanting to discuss our shortcomings. But I think just asking and saying, hey, is there a possibility that this was a perforation because of the difficult dissection, or was it because of the tumor itself?
Right. So actually, just to add, I was with Nicole that day to go over the specimen, and she pointed out that this is the defect, which is not really tumor perforation, and in fact, the tumor was the case was signed out as PT3. So, and coming back to that question, and as Nicole pointed out, so it won't be a T4, right?
Right. Yeah. Exactly. It wouldn't be a T4 if it was perforated by the surgeon.
Right. So there is another question. What about small lymphovascular emboli versus large vessel invasion? Does it make any difference in the management?
As far as I know, it wouldn't. So I think maybe the oncologists are a little bit more nuanced in the way that they interpret these things. But I think if you have any kind of lymphovascular invasion of small vessels or larger vessels, I think that patient, unless they had other risk factors that they wouldn't get chemotherapy anyway, those patients would be getting adjuvant chemotherapy.
I see. I think these are the questions that I see online, and there was another question which was basically the same question, like based on like the difference between small vessel versus large vessel invasion. So thank you again, Nicole, for this excellent discussion, and thanks to all our viewers for participating and for their active participation and asking very relevant questions. And this is the first time that we had a surgeon's perspective of dealing with colorectal cancer in our report, which is really, really very important to us. And Nicole, you will be very happy to hear that we had viewers from so many different countries beyond timelines. I just name a few. Apart from US, we had viewers from Malaysia, United Kingdom, India, Russia, Taiwan, Israel, Kuwait, Peru, as far as Burma, Ukraine. And thanks so much, viewers, for joining us. And as always, if you like these lectures, please take a moment to subscribe to our YouTube channel, and please follow our Facebook page, that is Pathcast, and stay tuned for more lectures. And in fact, today we have another lecture coming up that will be at 1 p.m., which would be on placental pathology, and that would be delivered by that would be coming from Mass General Hospital in Boston. Please stay tuned. That's at 1 p.m. Eastern time. And thank you again, Nicole, for your wonderful presentation.
Well, thank you so much for the opportunity. It was my pleasure.